We'll wait for a couple of minutes. Joel is not going to be able to join today. I know he was in transit. He was flying somewhere for a conference.
I might join, but not do audio just so I can see the texts.
Okay.
Okay.
Yeah, okay, so I won't worry about the chat box.
Okay. So there's no audio over here. That's cool.
I normally give a minute or so for folks to roll in. So I think we're at 45. So maybe we can go ahead and get started. Thanks everyone for joining the N3C Community Forum weekly meeting. This meeting is being recorded. So we have a couple of great topics today. One is the COVID and rare disease. Bryan and Melissa will be presenting on that. And then we have Leonie and Dave talking about the N3C dashboard, the second version 2.0 of that. Quick announcement on the upcoming presentations. So we have April 18th, semantic clustering, as well as the monthly recover long COVID update. April 25th, we're still trying to confirm the presentation for that. May 2nd, it's practical machine learning for COVID-19 using EHR data. It's a case study using a N3C. May 9th, BARDA challenge updates. And then May 16th, the use of cardiopulmonary exercise testing and addressing issues like fatigue in pediatric task. All right, so this is our public dashboard weekly update. This is a public dashboard, so everybody should have access to it. I'm going to turn it over to Melissa. I'm going to stop sharing my screen and turn it over to yourself and Bryan for your presentation.
Great. Well, while Bryan is pulling up the slides, I wanted to point out a couple things. One is that we've now unfortunately reached 3 million patients, which is both a wonderful testament to the community with 72 institutions sharing data, but still a sad number given that the pandemic continues, although currently in a bit of a lull. The other thing I wanted to point out is that I am here today together with Bryan in the same room. So we are presenting on the same computer, and how wonderful it is that we're able to do that safely now. So hopefully many of you are doing the same. So we're really excited today to present the work that mostly Bryan has been doing, but we have some ideas for where we're going to take this work at the end, and really look forward to everyone's comments and suggestions, and hopefully joining forces on some of the rare disease work. So with that, I'll hand it off to Bryan.
All righty. Hello, everyone. So yeah, we're going to talk about, COVID and rare diseases today. And, obviously talking about, there's always a little bit of a concern with rare diseases because there are so many rare diseases, but collectively, but individually, those patient cohorts can be very small. And we're always a bit concerned, that those patients can be overlooked. So I'm going to start off kind of telling a little bit of a story. Back in around 2019, we started off a collaborative project between OHSU, NCATS, Eversana, and Stanford Health to assess rare diseases in various healthcare and health-related organizations to get an idea of rare disease prevalence. And in doing so, we were looking at that data, and then kind of a funny thing happened in 2020. I think most of the people on this call are probably very well aware of what happened in 2020, that there was a bit of a pandemic, and our rare disease work kind of got shelved for a bit as we were focusing on preparing working towards studying COVID and rising to the COVID response. Personally at OHSU, I was helping put together our OMOP data model so that we could contribute to the N3C enclave. But as the pandemic continued on, we were finally able to get this work finished and published. And I was going to start off just talking a little bit about that as we were kind of continuing to look at, prevalence of rare diseases across these various organizations. And I know this is a table which is never, fun to look at, but, at just the take-home message from here is that, at these individual institutions, the prevalence of these 14 rare diseases, can be highly variable, but also that, depending on the organization, sometimes these patient cohorts can be rather small. In which case, if you're trying to do a research study on that particular rare disease, you may not have the appropriate statistical power for some of your analyses. It's a little bit easier, if we take a look at this data, from another, from a different visualization. So this is the same data, but just showing it in a graph format. And here again, you can see that there is a great amount of variation. Between the different health systems and amongst the various rare diseases. And, some of that can be attributed to, just the population distribution of the various rare diseases and also, the available specialties at each of the organizations. For example, if a particular organization has the appropriate, specialties and expertise, to deal with cystic fibrosis, for example, they may serve as a hub, that would be attracting more patients than some other healthcare organizations. But another thing I want to look at, from the paper, is rare diseases, because they can be very rare, by as far as patient cohort sizes, but collectively, they do make up a significant proportion of the population. And here we're looking at total costs, between these various rare diseases. And one of the things that you'll notice in this graph, is that on the left side of each of the graphs, we have a age-matched control population compared to the rest of the rare disease cohorts. And although the control in some cases, in most cases will be, have greater costs compared to each of the individual rare diseases. A couple things to notice that, one, collectively the patient counts are fairly similar collectively between all of the rare disease cohorts, if you combine them, and collectively the costs will exceed those of the control age-matched population. So in thinking about this, just recognizing that the total costs incurred at an organization are dependent on that size of the patient population, and while total costs for individual rare disease cohorts might exceed an age-matched control, collectively the rare disease cohort costs are greater than controls. And additional thing to think about, as I'm talking about costs, we are, of course, we don't have costs available within the N3C enclave, but those costs, do represent healthcare utilizations. So even though we can't slice the data by costs, we can look at the increased numbers of encounters, medications, procedures that would be associated with these rare disease patients and their healthcare trajectories. And here, this is just another way to slice the data. We're looking at patient costs per patient per year. And across all of these diseases, you'll see that compared to the controls, the cost for the rare disease patients, typically will exceed those of the control patients. So in thinking about all of that, again, just note that the individual rare disease patient populations are small, but collectively they are make up a more significant proportion of the population, as much as 10%. And while we do have a large, we have a large population of rare disease patients in N3C, and we can therefore ask several questions about COVID effects on rare diseases, and also look to building computable phenotypes at scale. And I do have some data that I'm going to show here in just shortly. But first, talking about this project, we've been working for a while trying to get this project up off the ground, and we have a DUR submitted and close to getting approved. And associated with that DUR, we have several project goals. Starting off, very simply, we're going to take the 14 rare diseases that we studied in the Ideas Initiative paper, and we're going to identify, what the prevalence of those rare diseases are in the N3C enclave. Other ideas, we're thinking about taking an approach of trying to cluster rare diseases by their phenotypes to attempt to identify, key phenotypes that are associated with negative outcomes. And this, may have the potential benefit where, some of the rare diseases, that might have really small cohorts. If we can cluster them with other similar rare diseases, we might have more statistical power when we go to analyze the data and their outcomes. Let's see. Additionally, we're looking into, identifying, rare diseases that have increased risk of negative outcomes from COVID, as well as identifying, rare diseases that have increased risk of long COVID. And additionally, we also want to determine, if there are certain rare disease phenotypes that might be exacerbated by COVID, and whether or not there might be specific interventions that could ameliorate COVID or long COVID. So heading into the data, one thing I did want to mention, just be noted that this data is very preliminary. We're just kind of getting things up and running. As I walk you through this, just keep in mind, this is not yet validated. It's just preliminary data. But for our 14 rare diseases, I went ahead and put together some population counts so that we get to look at each one of the diseases and see what the prevalence was like in the enclave. And here you can see, depending on the disease, greater than 50,000 patients for cystic fibrosis, all the way down to Takayasu's arteritis, where we have less than 1,000 patients. So as you can see, things can be highly variable even in the enclave. But the great news is, for many of these rare diseases, we'll have much greater patient populations than we might encounter in a single healthcare organization on its own. So we can definitely benefit, from having the 70 plus data partners and having that data combined. And again, kind of going back to that table that I showed you previously, I went ahead and added, the patient counts and the patient prevalences in N3C just for comparison's sake. But again, obviously tables are a little bit busy to look at. So if we take a look at the patient propensities in a graph format, you can see that, in most cases, not only will we have, larger patient counts, but here looking at prevalence, the thing that you'll notice is that N3C, which would be these blue bars, in many cases has a much higher, prevalence compared to the other organizations, and including, the medical, what would be expected in the medical literature. It's kind of there's definitely some interesting questions, that could be asked, exactly why that is, including, whether or not this is just a artifact of, the patient selection process as we're pulling patients into N3C, but also just a makeup of the data partners as well, who may be, specializing in certain healthcare services that might benefit some of these rare disease patients, and they may collectively, seek out those organizations for their healthcare. Let's see. So in addition to looking at patient prevalences, I also wanted to look, get some initial numbers just to determine, what is the COVID severity, across all of the rare disease patients. And if we compare, here, this is just a pie chart just showing, what the severity would be across, the entire N3C enclave of COVID positive patients. And, typically speaking, you'll see about, a 2% of patients, are unfortunately passed away due to COVID, and there's an additional 1% with severe COVID. And then you can see the breakdown, by other severity ratings, whether it be moderate and mild with an ED visit, mild, et cetera. And if we go ahead and then link, just to mention, this is utilizing one of the enclave objects, knowledge objects that covers patient severity. So we're leveraging some existing N3C resources here. But if we link this up to our rare disease patient cohort, we can take a look and see, how many patients are, filtering out by which COVID severity, category. Here's just kind of like showing it by patient counts. But if we look at the next graph, it gets a little bit more interesting, where we look at things in a percentage, viewpoint. And here, one of the big takeaways is that I think, let's see, it was only eosinophilic esophagitis that had a lower percentage of patient deaths than as compared to the entire combined N3C population. So the second graph here, I believe that is only about 0.5%. But every other rare disease here had an increase, had death as an outcome that was increased compared to all N3C patients. And particularly, you'll notice that urea cycle disorder here towards the center of the graph. I believe the total percentage count here was about 17.5%. So urea amongst the rare diseases, urea cycle disorder, definitely had an increase in severity for COVID. Another thing we did is I went ahead and linked our rare disease patient cohorts to the long COVID prediction model, machine learning model. And, you'll notice that, the patient counts here are, lower than, the total population, just because we don't have predictions available for everybody. But, you can see that, and again, this helps if we, go ahead and split this graph out by percentages. Across the entire machine learning model, there's about a 7% prediction rate of greater than 0.75 for patients, predicted to have long COVID. And that actually corresponds to this green bar here that I've included across the top. And as you can see, again, eosinophilic esophagitis is the only one that kind of matches up with the rest of the population, whereas the rest of these rare diseases all had an increased percentage of predicted long COVID status. Let's see. Sure.
Okay, so I'm going to talk a little bit about kind of what we're doing to address some of the issues in studying rare diseases in the enclave, and specifically, what do we do about the rare diseases that don't have an ICD code? How can we identify these patients? And this has been a sort of long-standing career mission of mine, not just in an N3C context. So it's really a wonderful opportunity to further some of that research. And then also, how do we best leverage some of our translational rare disease ontologies that we've spent many years developing to help us leverage some of the analytics that are enabled by those types of resources for studying COVID and long COVID effects in the enclave. So just to quickly kind of remind folks that rare disease knowledge is distributed and not coded consistently. So this was a paper that we did a couple years ago where we basically were evaluating different knowledge sources for understanding rare disease content. And so here we're just showing 5 of the very many rare disease resources that are available. And we looked at all the different rare diseases and which concepts were included in different sources. And you can see over on the left, many diseases are only represented in one source, whereas many only for one of the resources, for one of the, in one context, just 5 sources comprised only 333 shared disease concepts. So of all these different resources, they really don't overlap all that much. And also, when we did this evaluation, we classified the number of rare diseases as being well over 10,000 rare diseases, whereas it's often reported as 7,500 diseases back from the 1983 Orphan Drug Act. And those numbers have not been updated since then. So while the number of 10,577 may not be exactly correct today, it's definitely more likely that we do have indeed more than 10,000 rare diseases, and we should stop referencing that 1983 number. But the point here is that when we look at all of this, over 7,000 of these rare diseases have no cross-reference of any kind to ICD. So it's not necessarily the case that we actually understand the relationship between any of our commonly used ICD codes and what the rare disease community is using for their classification. Towards that end, we have an ongoing effort to align these different rare disease concepts from all of those different sources with ICD-10-CM. And so this is a project that's being led by Nico and a number of other folks, where we basically are taking some work from the OMOP to OBO concept mapping that I'll talk about on the next slide, and creating a disease mapping commons to create proper, rigorous mappings. For those of you who know me, I have nightmares about mapping. So the idea here is that we keep the provenance and attribution of all of those different mappings, and then using a computational tool called Boomer, create these alignments that can then spit out the other end a more robust set of ICD to disease knowledge mappings that we could then use in the enclave as well as many other places. And so the OMOP to OBO mappings, which we've talked about on the forum a little bit before, and this is work that's led by Tiffany Callahan for her thesis work. She basically took a variety of OMOP concepts, such as from the conditions table, drug ingredients and measurements, and mapped those to translational ontologies such as Mondo and HPO, but also other ontologies such as the cell ontology and the Uberon anatomy ontology, the chemical ontology. And this allows us to then use, OWL-based reasoning tools and other methodologies that depend upon more rigorous types of ontologies. And so that's what's enabled some of the other long COVID work that we presented earlier and have ongoing as well. But here, it's really critically important for realizing the integration of that rare disease knowledge for use for the project that we're presenting today. Just as a reminder, I wanted to give people a little bit of an update of why is this really so important to us in the rare disease space. So for very, very many years, Peter Robinson, Chris Mungall, and myself have led the Monarch initiative and the development of the human phenotype ontology, which is a phenotypic characterization of patient features, but also this knowledge, it's represented as a graph rather than as a single hierarchy like ICD. And it also allows cross-references and integration with many other kinds of resources, such as the gene ontology, if we want to understand gene function. The way in which we've used that ontology is for semantic similarity analyses for diagnostic purposes. And this is important for what I'm going to show you about our clustering plans. Essentially, we've created curated profiles using the human phenotype ontology, shown here in the middle in blue for Wiedemann-Steiner syndrome. And then what we can do is take any given individual patient and describe their features using the human phenotype ontology. And using a semantic similarity algorithm, we're essentially looking for what's the best match of the set of features in a non-exact fuzzy matching type of way. And here you can see two different patients diagnosed with Wiedemann-Steiner syndrome that in some cases have opposite phenotypes, such as long toe versus short toe. And not all of the patients have all the features, and not all the features match exactly. So we're really kind of looking for a needle in a haystack in terms of trying to find the best match in terms of the semantic similarity of the patient's features with our known disease profiles. If we take all of those profiles, we can actually cluster them, and we wrote a paper a number of years ago to demonstrate the relationship between phenotypic similarity in disease clusters, looking at rare diseases and common diseases together. We want to do something similar now within the N3C enclave. And so we have a lot of clustering work going on in the machine learning group, as well as in the Recover Long COVID group. And we want to enhance that work here to apply it to the rare disease context. So taking those curated rare disease profiles for all of we have almost 8,000 disease profiles curated for rare diseases, and convert those into OMOP profiles, and then use those OMOP profiles for clustering and developing computable phenotypes for rare diseases for which we do not have ICD codes based upon these phenotypic profiles. And then we want to also examine how do we split up these different disease areas by phenotypic category. So for example, if we want to understand the effects of rare diseases, the effects of COVID on rare diseases that have significant immunomodulatory phenotypes, then we could cluster looking specifically at those diseases together. And then also just overall looking at analysis of different COVID phenotypes and severity, and looking at the sort of intersection of those by the different rare disease clusters. And then finally, and most importantly, the opportunity is really unique in N3C, given the size of the cohort, to actually have enough rare disease patients to really look at some of these phenotypic characterizations, as well as their intersection with acute COVID effects, interventions, what rare diseases are actually less affected, as Bryan showed some of our early work, trying to understand which rare diseases might actually have mechanistic underpinnings that mean that those rare diseases are less likely to have severe acute effects or not otherwise be potentially classified as long COVID. So I wanted to thank Kate Bradwell in particular for helping us develop some of the code sets that we've been using for this work. And so we started with the 14 rare diseases from the ideas paper as a starting place and as a mechanism to collaborate with the Office of Rare Disease Research and our other collaborators that help with that program. We are working on developing a rare disease phenotype library and rare disease fact table that can be used by the other projects and domain teams. And then also we will be sharing our methods and results of the rare disease clustering strategies that I mentioned before. And then we also have many more code sets coming. I know there's a number of different domain teams that have some rare disease interest, and we'd be delighted to work with you to help develop those code sets as well. So should I hand it back to you?
Sure. Yeah. So, in thinking about rare diseases, one of the things to think about is just, that these do provide, a very unique circumstances for studying COVID. And, we need to take some pathways, in order to get that going. So initially, we'll be looking at, identifying patient cohorts, with and without, ICD rare disease codes. Obviously, the ones with the ICD codes are going to be much easier to identify, but we can try to identify those without rare disease codes by looking at their phenotypes and comparing those, to existing or known disease to phenotype mappings. And, we'll be looking at, looking into the uniqueness of pre-existing phenotypes and whatnot, and trying to build, computable phenotypes for rare diseases. But also looking at rare diseases, we also want to look at, the uniqueness in the response to SARS-CoV-2 infection. But we can also look at these rare disease patients, they're going to be on medications, they're going to have procedures, and there's going to be various observations that may not, occur, with your non-rare disease patients. So there are definitely unique circumstances available, to look at interactions between, pre-existing medications, pre-existing procedures, et cetera, and how those are affected by SARS-CoV-2 infection. And importantly, we'll have the opportunity to identify, rare diseases with increased likelihoods of greater COVID severity and negative outcomes, as well as, any of the positive effects that we might see in looking at those interventions and how the patients react to them. And then, of course, hoping to, reveal any mechanistic insights, and understandings of both rare diseases and COVID and long COVID. One of the things we wanted to talk about here is just, we do our best to be, very collaborative, and N3C as a whole is a very, collaborative project. And, we want to make sure that our rare disease work isn't aligned with the other projects, so that, not only, can we leverage, the existing, resources and expertise that are out there, but then also, contribute back, where we can, and, try to push things forward and, allow everybody to, start looking into rare disease research within the N3C enclave. Just to highlight it here, just a few different things, that we were brainstorming, that, could be useful for studying rare diseases, as shown by some of the preliminary data I showed earlier. We can use the long COVID model predictions, and we can look forward, as we're seeing, greater usage of the U09.9 diagnostic code and seeing how that's showing up in rare disease patients. But then also, as other data types become available in the enclave, if we get the variant information, we can look at COVID outcomes in rare disease patients there. Similar as in a similar vein, as a vaccine status, becomes available in the enclave, we can look at the effectiveness of vaccines in these COVID and rare disease patients. One thing I forgot to mention earlier, in thinking about like clustering patients, there might be some natural, splits in rare disease populations, particularly, in any patients that have rare disease phenotypes that are immunomodulatory or immunosuppressive. Would be very interesting to look at, the vaccine effectiveness in those patients. And then another thing, with rare disease patients, kind of getting back to, the costs, that these patients incur, and those may or may not, be covered, by their insurance programs. It would be really nice to look at, rare disease patients as it relates to social determinants of health, and, see how any increased, SDOH related impacts might, be affecting these rare disease patients as they're trying to, battle COVID. And last but not least, there are many, N3C domain teams, and rare disease research, just due to the variety of phenotypes that these patients may have, the rare disease research is going to wind up, spanning an incredibly large number of research domains, if not all of the domain teams, that we currently have in N3C. So definitely, we would hope to collaborate with as many teams as we can, going forward. As far as thinking about anticipated challenges, one of the things with the enclave is we don't have any data for patients that exist prior to 2018. And here on the left, I have a patient trajectory that was created by our collaborators Eversana for the ideas paper, and in kind of thinking about how, the importance of kind of being able to look at the entire patient history. If we're cut off with to only having post 2018 and later data, if depending on where 2018 would fit on this graph to the left, there's quite a number of significant healthcare events that depending on where 2018 is on the graph, we might wind up missing out on. And in addition, the other thing to look at as well is, if assuming this would be like a COVID positive patient, where that COVID index date would fall in that patient trajectory, could have an immense, effect on the patient's response to COVID. For example, here, one of the largest spikes you'll see as far as costs go is a double lung transplant and an ICU visit. Depending on where the COVID index date falls in this graph, you could definitely see how that patient trajectory and the response to COVID could be greatly affected compared to later on in the graph where they're getting treated properly and they're more at like a maintenance level, if you will. And then let's see, and in thinking about that, it does kind of help make the case that if going forward, as we're working through studying COVID, and considering other uses for the platform, there could definitely be a case made for trying to expand the data that we have available, particularly for rare disease patients, in addition to other use cases out there, just because it's a great platform and it's a great environment for research, but we might need to have increased data in order to really truly analyze some of these patients that have more complicated healthcare histories and healthcare trajectories. Let's see, now I think we're getting near the end of our slides here. So far, these are just the individuals and organizations that have signed on to our DUR so far. And again, just want to say, we definitely want to be as collaborative as we can be. So anybody is welcome to join. Would very much enjoy if anybody wants to sign on, reach out, and we'll definitely get you added onto our project. And I believe that is everything. Are there any questions? And just wanted to say, also want to say thank you.
Hey, Bryan, Melissa, I see one question posted over here, so I can read that for you guys. It's from Ali Ranawat. Are there any public data sets containing genotypes and genetic composition if one wants to explore rare diseases and study about it?
So there are, in fact, well, there are many different data sets that are out there. And in fact, some of the work that we've done in the Monarch initiative is really to collate and integrate many of those resources. And if you reach out to me, I'm happy to set up a call or send you some links and things like that. It is actually, though, maybe what the question is more geared towards, can we bring any of those data sets into the enclave so that we can kind of combine some of that, public data with our N3C enclave data, and that we have, in fact, and thanks to Justin Reese at LBNL, have deployed some of the work on knowledge graphs in the enclave, where we can kind of bring together some of the different mechanistic basic research, but we haven't yet brought in any specific content that's focused on rare diseases specifically. And so I think that's something that we want to do. Part of that is that OMOP to OBO work and sort of leveraging some of the translational research ontologies in that context. But there's a lot of data sources out there that have, rare disease genotype, phenotype data, or otherwise similar data coming from model systems or even proteomics data. So I would love to explore kind of what we might be able to do with either the PPRL or with external data sets and bringing some of those in for this rare disease project. So Ali, I'd love to talk to you about your ideas if that's what you were getting at. Feel free to try to follow up. I'm not sure if you're on the panelist list or not. And I think, obviously this is very early days, but we wanted to get it out in front of everybody so that you knew what was happening and how not only are we building on some of the great resources from our own historical work, but also some great resources that have been, really coming to fruition, focused on the clustering and machine learning work that's been going on in the enclave and in the long COVID recover work specifically. And we would just, really welcome expertise. There's also, I think, we're starting to see some really interesting, signals specific to certain disease types, as Bryan showed, that may be more severely impacted. And I think we really are also looking for clinical partners to help us validate some of these results and ask the right questions of those patient populations. And then finally, also for those of you who represent your institutions, Ken Gersing has presented on our ideas around the tenant model for using the N3C for sharing data in more different kinds of contexts, not just for COVID in the future. And that limitation that Bryan pointed out that limits us to looking only back to 2018 is really limiting for understanding longitudinal trajectories for rare disease patients. But in that sort of tenant model, an institution might be able to share additional data about those rare disease patient populations, but then control access to a more limited group of researchers for more limited specific areas of focus. And so that's the kind of thing we really want to encourage people to start to think about, what kind of infrastructure and governance would work to allow us to share data before that 2018 date. And also rare disease patients who aren't making it into the enclave because they weren't a COVID positive patient or an age matched control, because we're not matching based on rare diseases for the inclusion criteria. And so we know that there are many more rare disease patients in institutions submitting data that aren't currently in the N3C data set. So really excited about the idea of expanding N3C specifically for collaborative analytics in rare diseases across the nation.
Hey, Melissa, thanks for that. So I see another question in the chat. Tina Irv, who's the director for RDCRN, Rare Disease Clinical Research Network at NCATS. She asked if you could do this presentation to be the RDCRN group.
Oh, absolutely. We would be just delighted. And we would love to try to figure out how can we, grow our infrastructure and as well as our methods to help support the RDCRN specific areas. And we at Colorado participate in many of the RDCRN programs. And so I think there's a natural synergy there. And I think we, as Bryan had mentioned, we're finally, kind of mature enough on the N3C side, as well as integrating some of our earlier rare disease efforts and clustering efforts and ontological methods and these kinds of things, that we're much more well positioned to help support the RDCRN work in this context. So we would be really just delighted if we can explore some partnerships, and happy to come give a presentation.
Sounds great. And Tina, I can coordinate with you and Melissa.
Yeah, and just her comment about tapping clinicians, that would be absolutely phenomenal. And maybe we could even come up with some kind of working groups or things like that. We've made the DUR for the rare disease work intentionally broad and inclusive. It's, I suppose it probably should be a domain team of sorts, but we haven't officially made it a domain team. We're kind of looking to see what kind of interest there is first and just trying to get going. But it is really open to everyone. And it may well be that with the RDCRN potential partnership, maybe we can break it up into some smaller, more targeted methods and disease areas with clinical expertise.
Great. So I don't see any other questions, and I do want to be sensitive about time. I think we're going to turn it over to Dave and Leonie for the dashboard presentation.
All right, thank you. I apologize for not having the camera on. We've had some power and networking issues around here today, and I'm tethered to my phone at the moment. So hopefully I will stay connected with you during all of this. Oops.
Great. So is either yourself, Dave, or Leonie, are you guys going to present the screen?
Yes, I am, and I just realized that I need to unlock my screen. I had to switch devices. All right, so I'm back. Sorry. So the where we're at with this is that the dashboard, as it was originally conceived, was very limited to the notion of the type and talk at the same time, to the original cohort characterization paper. And so we decided 2 years into this that it was time to sort of take a step back, think about who our target constituencies were for this, and then do a more persona-driven design of the system. And much of what you'll see here is a result of Will Cooper on my team having some extended interchanges with various user populations and so forth. So this main page you're seeing here.
Dave,
Yes.
we don't see your screen.
All right, let me try that one more time.
Sorry.
How's that?
Much better.
My normal Zoom environment is offline at the moment, so my apologies. So the prospect here is that this main landing page is really designed to take an incoming user to one of effectively 4 independent dashboards. The first one, N3C exploration, is really meant for the casual public, for potential investigators who are just trying to kick the tires and decide whether it's useful to go further with the environment. The administration one is more targeted towards NCAT and NIH in general, and the sites in terms of the questions that we tend to get from the various sites. Public health is a much more drill down notion, and Leonie will be touching upon this component of the framework after I do the overview stuff. And then finally, the Recover Past team is starting to spin up some content. And so we're providing a dashboard for that. So exploration, as I was saying, basically very, very high level overview. Some of the statistics that we show to you folks on a weekly basis are distilled here in a way that are intended to be sort of generally consumable. This interface is really meant for that kick the tires notion, so that you can see the various distributions of age, gender, race, ethnicity, and severity, but also you have the ability to come in and say, well, I'm only interested in 65-year-old males. What does the data look like? And you can see that we're seeing very distinct distributions here. You can actually see this in tabular form as well, but the notion is to be able to do very coarse-grained exploration of the nature of the data without having to go through the effort of getting registered in the environment and so on. And then clearly you can reset to scratch here. Next piece from here was, well, where does the data come from? And in this regard, we're really looking at the variety of sources of information and the status of that information. The smaller dots you see here are the ocean contributing sites, but then the ability to pick a locale, and this is particularly useful within the more crowded environments, and see in a zoom factor just where a cluster of sites is going by zooming in far enough. This is actually, if we zoom back out again, selectable, so you can say, I'm only interested in, say, the CTSAs, and restrict the information down to here. So that the map and the table interact intentionally. What are researchers studying? This is basically the roster of public DOR stuff that's currently present on the system. Again, same information that you see in the current production dashboard. You can come in and go hunting for a particular notion of, say, diabetes. And if I can type correctly, you'll see restrictions there. And then the same thing's true for scholarly output. If you're interested in hunting down, say, an individual author, you can actually identify individuals there. So exploration, again, really meant to be very light touch, very approachable. And as we've been very intent on targeting with this, much more usable in a variety of devices, including tablets and phones. Administration comes back to more of a deeper drill down on some of the specifics that people tend to track on a regular basis, but then also some of the information that we've seen within the admin tab on the other side, number of institutions, user information plots, same kind of visualizations here that we've had prior with respect to the growth of the enclave over time. Again, map here, same zoomable mechanisms, same kind of constraints and selection here on domain teams and projects. And then finally, some new content. This is a graph of aggregated institutions. So for instance, the winner in terms of just raw number of people on the enclave is Johns Hopkins, selecting all the projects that they're on. And then likewise, the biggest project with respect to number of individuals involved is characterization of long COVID. Again, the key for this is the projects are in blue, CTSAs are the orange, CTRs are red, gov, commercial, and so on. And then if you're really interested in messy graphs, you can do this at the individual level. And if you know where to look, you can even find an individual like Ken Gerstein and figure out just what he's involved with in here. The operational DURs isn't as much of an interest, but at the challenge grant, this is the pediatrics challenge, this one here, and you can see that there's a large number of CTSAs involved at the individual level, but also a large number of unaffiliated individuals. And then the respective project that they're connected to. And then when you aggregate this was actually somewhat of a surprise. The majority of those unaffiliated individuals are coming from two institutions, Arizona State and Oslo University Hospital. So my suspicion here, given the node sizes here, is that these were actually classes that signed up as a whole, where they were doing machine learning coursework and used this as their target project. Public health, Leonie will be touching on here in a moment. This is pretty much what you see in the existing, and of course you're not going to load for me, existing notion of adult summary data. The pediatric stuff that Tel Bennett and his team are working on is actually also here. And then finally, Recover is the long COVID work, and the preliminary content that we have here mostly derived from the existing long COVID paper that is out. One thing that, if you notice very closely, I can come in and say, select training cohort. And unlike the existing system, doing a reload takes you right down to that existing tab. The intention here is these are bookmarkable URLs. So the primary goal here is to target the ability for individuals to hand out a URL, say, go to here, and you can see specific content without trying to describe a navigational path. But again, general function here is to support the ability to have this be a much more structured and yet directly referenceable environment for the community. And I guess at that point, I will hand it off to Leonie.
Thanks, Dave. Going to share my screen, hopefully the right screen. Can you see my screen?
Yes.
Okay. So I'm going to keep this quite short, just taking a look at time. From what Dave said, right, I'm going to focus on the public health, and really, going back to what Dave said, the premise here really was what's in the data. So the most common question we got was, before we go into the database, we'd like to be able to see what's in the data. And the most common question was, what's in it for me? So we had policymakers. Can you still hear me?
Yes, we can hear you, Leon.
Okay. So we had policymakers, researchers who really wanted to see this. So if I can actually get this to work, I'm going to just walk you through this really quickly. So right now on the public side, we have about 10 of these dashboards that includes, the adult summary data, pediatrics, medications, commonly used medications. And these were put forward using, we had a working group, a public health tiger team in place, who actually asked who provided some information and asked a few questions on what's most useful for the community while we walked through it. And so the adult summary data, as an example, has demographics data that you can slice and dice on: race, age, ethnicity, gender. You could use any of the these filters to be able to filter it. So if you wanted to see mortality, for example, you could do it from here, or you can do it from the filters, and whatever you select will also show up in these various categories based on the selection. Now, on the same demographics, and I'm sorry, I'm having internet problems, we also have data on vaccinated and comorbidities, unvaccinated and so on, that you could go in and take a look at. We've got similar data on pediatrics. And then I'm just going to, again, go through this really quickly because we've got, what's the best data on medications, for example, where you have classes and medication types. And hopefully it actually pops up. But in the meantime, while it's doing that, we've got information on, say, cumulative average COVID cases. And if you look at this graph, you'd see that these peaks match up with, say, Delta and Omicron. And so the N3C data really is very similar in falling out in patterns in terms of how many cases we had for COVID and what were the 7-day rolling averages. And that's the same for cumulative and the other graph. There's also reinfection data, which shows, how much of us, the first one shows how much of the first cohort actually got reinfected. So for example, the cohort on November 5th had 13,000 people who had first diagnosis of COVID. Of those people, 619 actually got reinfected. The second graph says, it really is just showing actual numbers. So on that day, how many people were infected for the first time, and how many of those, not of those people, but how many more people were infected. So in this case, if you're looking at, the 20th of January, which is still Omicron, there were like 14,000 people infected, and an additional 1,000 were reinfections. As an example. So just to remind you though, that this is just a snapshot of data. We're not making any hypothesis or non-hypothesis based scientific outcomes from it. And each of these dashboards has a limitations, its assumptions of the data on it, so that you know how these data were pulled and what the limitations are for each of these data. In that same way, we have information on diabetes, for example, as an when you're talking about diseases, what was the prevalence before and after COVID, and what was the prevalence in 30 days after diabetes diagnosis. We have similar information for disease snapshots, where we have like 17 or so diseases most commonly in the system, where you can look at similar kind of data. So what's the cohort that's available? And one of the asks from the community was the information on the inclusion of race and ethnicity, where you could have cumulative participant data that could be used when applying through the IRB, right? So what's in the enclave across the complete enclave of, it's showing 12 here, but it's really 13 million at this point, based on race and ethnic categories. The good thing about this one is you can actually download this data in an Excel data table, and then use it when you're applying for, say, an IRB. So at this point we've got regional information, we've got smoking data, disease snapshots if it's loaded up here, cancer, for example, in a similar situation of before, after COVID diagnosis and prevalence, and we've got it for all the 17 or 18 major types of diseases. We've also got a few dashboards that we're working on, reinfection time series, long COVID, just numbers, mortality. And mortality, and particularly I'm pulling that up, is one of the dashboards where we used an external data set for PPRL, where where data has been added in from 3 different mortality sources, and the number of participants that passed away or died, who had COVID, for example, 28,000 here, but also what's called delayed mortality. How many of these participants were COVID positive or had a code for long COVID, were released from hospital and then died after they left hospital. Now, one of the caveats here, again, is a good thing to go check limitations and assumptions of the data. Even though this shows that half of the participants actually passed away within 30 days of being released from the hospital, we don't know the cause of death, or it's not part of the record. So the point here is this set of dashboards provides your first step into what's in the data, and then we're providing the preview, for example, and it's up to you, the community or the researchers to go make the movie. So these, I'm happy to answer questions, but there's a lot of information. I am still waiting my favorite thing to come up, medications, which hasn't yet. But and sometimes you just need to wait for it to load. And within the medications too, we've got information on, say, the monoclonal antibodies, and they can be, you can again filter here for, say, the monoclonals, and be able to see the distribution of monoclonal antibodies that we have in N3C. So sotrovimab is right about here. We've got about 6,000 participants for sotrovimab and other antibodies. There's a lot of information here. Like I said, it's a peek in the data. that you can use to then go ahead and do further research. So I'm going to kind of stop here. I have just one slide that I need to share, and then I'm done for questions. If you could see my slide, this is, I just want to thank our team, the data team, the visualization team, the public health tiger team, who've been very, very, the data and visualization team has been very good at putting this up quickly and very agile in responding to all of the input from the public health team. So thank you. And we're open for Q&A.
I will note that the public health dashboard is up both on the current production system and on the new scheme. The new design we'll be deploying here in the next few days. We still have some text content that we're trying to roll in for the Recover team before we go live. Questions? Well, looks like we ended right on time.
I don't see any questions. And yes, you're right. We're right on dot. Thanks, everyone.
Yeah. Thank you.
Bye, everyone. Thank you.